So if they are ready to make a change, first thing you do is congratulate them. That's a huge step that they're taking. It's a big change. It's a lot of work that they're going to be going through. So you really want to make sure that you're congratulating those patients that are ready to make that change. And then we can start talking a little bit about the tobacco specific treatments, and those kind of fall into two major camps: counseling and medications. And then for any of those patients who want additional resources or maybe want to go on their own and kind of think things through themselves and maybe make up their own plan, we'll go through some additional resources for them too. As far as counseling and medications go, we know that counseling is good and medications are good, but it's really the combination of those two things that give your patients the best shot they have in reaching those, a third of patients with the optimal treatment will quit smoking at a year. So really you're talking about both the counseling and the medications that you're going to be offering to patients. As far as the counseling points go, there's kind of three main tenets that you're going to be hitting. There's setting a quit date, reviewing past attempts, and then anticipating the triggers that they're going to come across and ways to kind of cope with them. So as far as some of the pearls for when you're talking about setting a quit date, you're getting rid of all the tobacco products. So you're basically making it harder for the patient to reinstate their smoking habits or their smoking addictions. So you're getting rid of all the cigarettes, all of the lighters, all of the ashtrays, so that if they want to have a cigarette, they have to go to the store, buy the cigarettes, buy the lighters, everything like that. It just kind of makes them think a little bit more. It's not as easy to just grab that cigarette. And they pledge to themselves and their family and friends, if they're involved in the equation, no cigarettes, not even a puff, after you wake up on that quit date. That's a hard and fast quit date. So that's, like I said, that's a promise to themselves. With reviewing past quit attempts, you're talking about what worked for them. Some patients will quit with friends so that they have someone to commiserate all of the withdrawal symptoms and everything with. There's some patients that will save the money that they would be spending on cigarettes and put that into a fund to buy something really expensive or out of the ordinary for them. So it's like a nice treat when they reach their goal quit time. And then you're also talking about what led to past relapses if they've tried to quit in the past and haven't been successful. Getting them to kind of verbalize and recognize the problems that they had so that when those problems likely come up again, they're ready to handle them and kind of push through them and hopefully have developed some additional coping strategies to make this quit attempt successful. For anticipating triggers and ways to cope, things that you want to touch base on are the weight gain. Unfortunately, there is a weight gain associated with quitting smoking. It's usually about 5 pounds. Environmental cues, so what they can do when they're driving a car and they're used to smoking a cigarette while they're driving or having their morning cup of coffee, so that they can kind of start to think about how can I replace that automatic lighting up a cigarette, what can I do to help not do that? Being around other smokers is difficult, so talking with their friends and family, if they have friends and family that smoke, and getting their support and saying, hey, let's try not to smoke when you guys are around me, and ways to manage with being around other smokers when that does happen. Alcohol use is another big thing to touch on when you're talking about triggers for smoking, because like Dr. Piper said, with the alcohol and any addictive substance, it increases the level of dopamine in your brain, and there's kind of a kindling effect. So if you get a little bit of dopamine, all of a sudden your brain is going to want a lot more dopamine, and one of the easiest ways to get that is by getting a cigarette. So making sure that we're talking about alcohol use and kind of the consequences that can happen when people are trying to quit smoking. As far as medications go, there's really 3 big groups of medications, I'd say. There are technically 7 FDA-approved medications, but these kind of fall into 3 big groups. So there's combination nicotine replacement. We'll touch on all of these individually. Varenicline and bupropion. Technically, these are all first-line agents, but I think if you talk with a lot of the smoking cessation experts, the literature and the results are starting to show that it's probably more likely to be the combination nicotine replacement and varenicline as being the most efficacious medications out there for patients. So when I'm talking about combination nicotine replacement, I'm talking about both a long-acting nicotine replacement and a short-acting nicotine replacement. So the long-acting are the patches, and these are dosed based on number of cigarettes smoked per day in the patient. So if they're smoking more than 10 cigarettes a day, you're giving them the highest strength patch. Short-acting are things like the lozenges or the mini lozenge, gum, inhaler, and nasal spray. And the lozenges and gum are the ones that are available over the counter, as are the patches. The short-acting versions are based dose-wise on how soon after waking that the patient has their first cigarette of the day. So if it's within 30 minutes, they qualify for the 4 milligram, the highest dose short-acting. And to use these in combination, the idea is you have this kind of chronic low-level amount of nicotine in the system from the patch, but then they're also using these short-acting to get the bursts of nicotine when they need it. And most people will advise their patients to use them on a schedule initially and then on an as-needed basis, so that they're really, when they have a craving, they've got something to use that isn't a cigarette. These things are started on the quit day, and length of use usually around 12 to 14 weeks, but really kind of depends. It's most individualized based on patient needs and the difficulty that they're having with quitting that addiction. As far as varenicline goes, this is a nicotine receptor agonist and antagonist. So what this means is that the drug will bind to those nicotine receptors in the brain, produce a little bit of dopamine so that it kind of helps to combat those withdrawal symptoms. But it also, in occupying those receptors, if you do smoke, that nicotine from the cigarette can't get at those receptors. So all of a sudden smoking doesn't produce the same rush that it used to for you, and it's not as pleasurable of an activity. So for that reason, we do not combine this with nicotine replacement therapies. And this medication is started about a week before the quit date to allow the medication to build up in the system, and then the patient quits and they're just on the varenicline for about a 12-week course is kind of the usual time frame there. You do need to have some consideration as far as who this medication would be appropriate for. You want to definitely use caution in patients with kidney disease, but also unstable heart disease, coronary artery disease, and severe psychiatric illness. So this medication is not available over the counter, it's only available by prescription, and you do need to have some consideration, like I said, about who you're prescribing this medicine for. Bupropion is the last first-line treatment, and this is an antidepressant, so it works to help reduce those cravings and kind of the negative affect that you get with the withdrawal symptom. Likewise, this is also started about a week before your quit date, and then it's about a 12-week course or so. And in this, you also have to have some judgment as far as who is most appropriate for this medication. You're going to want to be cautious in anybody with a seizure disorder or conditions that increase the likelihood of seizures, so things like heavy alcohol use, use of benzodiazepines, things like that, and then anybody with severe psychiatric illness because it is an antidepressant. So again, good medication, probably less efficacious with some of the newer evidence that's coming out, and does need to have some consideration as far as who this medication is appropriate for. Medications in pregnancy is a tricky subject. There is some research out there, and kind of the best information that I can give you is that it's best if she is able to quit on her own or with counseling, but if you really think that she's not going to be able to quit, or if you think that the lack of medication is really going to hinder her, then either nicotine replacement therapy or bupropion are the two most commonly used medications when someone is pregnant. We always want to discuss the risks and benefits of smoking cessation medications versus smoking. They're both chemicals. I think you have more chemicals if you're smoking a cigarette, but you still have the intake of chemicals, and there's not super great research on what happens to both mom and baby taking these medicines. So if you do have to use them, you're using the smallest effective dose for the shortest time possible. So what a lot of people will try to do is just do the ad lib treatment, where they're using those short-acting lozenges or gum, lowest dose, only when you have cravings, and then it's not a continuous supply of medication if you have the patch. and hopefully using it for a really short time. But again, you've got to have that discussion about risks and benefits to mom and baby. The additional resources that I alluded to earlier, there's a couple of really great ones out there. I really like the smokefree.gov website. I think it's a very nice, patient-centered, in-depth website that goes through some of the strategies and gives patients a lot of really great information. There's 1-800-QUIT-NOW, that's the national tobacco quit line. Each state has their state-run quit lines, so if you called 1-800-QUIT-NOW in Wisconsin, you're automatically sent to Wisconsin's quit line. They offer free telephone counseling sessions as well as 2 weeks of cessation pharmacotherapy. Great resource. And then you can also direct your patients to go to their local hospital or their local healthcare organization, because a lot of the bigger organizations will have smoking cessation treatments in place. Like CTRI, the Center for Tobacco Research and Intervention at the UW. The VA has good smoking cessation protocols and clinics and everything. So having them check with some of their local organizations is another way that they certainly can go. And the big new thing is that with the Affordable Care Act, now insurance you have mandated coverage for 2 quit attempts per year with FDA-approved medications and counseling. So if it's a cost thing that the patients are worried about, hopefully this will start alleviating some of that and will really kind of get folks over that barrier so that it eliminates that barrier to having them quit smoking. If you have patients then that aren't ready to change, when you're assessing them to see if they're ready to make a change and they say, I'm really just not ready for that change, I've got a lot of stress in my life right now, there's a lot of big changes going on, that's okay. It's like Dr. Piper said, treating addiction is tough. It's something that they have to work at and they have to be ready to do. So in this case, there's motivational interviewing. And this is really a decisional balance exercise to help develop discrepancies between what they like about smoking, what they don't like about smoking, and kind of starts them thinking about that change and kind of hopefully getting them ready to make that change. So some common questions that I'll ask folks is what they enjoy about smoking versus what they don't like about smoking. One of the common answers I get is that smoking really helps me to calm down, it helps me manage stress, everything like that, but I don't like smoking because it costs a lot of money, and I don't have a lot of money, so that puts a lot of extra stress on me. So that kind of, then they start to recognize, I'm causing a lot of stress because I'm smoking, but smoking helps me alleviate stress. And so it just kind of starts those wheels turning, like I said, and hopefully getting them ready to make those changes. Other questions you can ask them, what would they like about being smoke-free versus what wouldn't they like about quitting? And it's really important to be supportive, to be empathic and non-judgmental when you're having this conversation. Patients need to feel safe, and we'll talk about that in a couple of slides here, but in order to have effective conversations with patients, they have to be comfortable with you, they have to feel safe. So you can't try not to sound demeaning or degrading or putting their addictions in such a bad light that it just makes them clam up and not want to talk to you. So arranging then is the last step for tobacco treatment, and it's arranging follow-up, and this is extremely important both for the patient and for you as a provider. We know that addictions are a chronic illness, so you have to keep treating them just like you would keep treating high blood pressure or diabetes. It helps patients know that they're not alone when they have follow-up. They say, okay, I'm going to get a phone call in a couple of weeks. This will be really nice to touch base. And it helps providers know that they're not alone. So you're not shouldering all of the callbacks and all the follow-up visits all on your own schedule and everything. It really helps to kind of even out the work. And we know that multiple contacts are always better than single brief interventions. At those follow-up visits, you can also talk about medication adherence. A lot of folks won't use the short-acting nicotine replacement as much as they should, so you can help them kind of use that on a more appropriate schedule to really help with their cravings. And you can also talk about side effects. Maybe they're having side effects from the varenicline or from the patch, and those medications are no longer the most appropriate medications for them. And finally, you're talking about relapse prevention. So what do you have coming down the next couple of weeks? Is anybody graduating? Is there any big job changes, anything like that, so that you're really kind of doing that anticipatory guidance and coping strategies. So shifting gears now into alcohol treatment. We're still going to be going the 5 A's route, but the A's are a little bit different for alcohol. We've got assess, advise, agree, assist, and arrange. So, like I had mentioned previously with the sensitive nature of some of these topics, alcohol in pregnancy is a particularly sensitive area. Women know that drinking isn't good for themselves and it isn't good for their baby. So when you're screening patients for alcohol use during pregnancy, you really have to be cognizant of that and allow a safe space to occur to allow that conversation to happen. And so with that, there's different screening tools that have been validated specifically for use in pregnant patients, and one of those is TACE. So this is one that I know my baby and me uses, and we'll talk about their protocol at the next slide, but just to review very briefly, TACE, the T is for tolerance, so how many drinks does it take to make you feel high? More than 2 drinks is positive. Have people annoyed you by criticizing your drinking? Have you ever felt you should cut down on drinking? And have you ever had an eye opener or a drink first thing in the morning to help with nerves or a hangover? And this screen is positive if the patient scores 2 or more points, and you get 2 points for the tolerance question, 1 point for the A, C, and E questions. And so the screen that my baby and me uses is based off of TACE, but it does some really neat things, and I like the My Baby and Me screen a lot. It incorporates a lot of different aspects of the screening process, so you get to understand the patient's knowledge and know where the patient's coming from as far as, do you know the consequences of drinking and smoking, more drinking with pregnancy. It also will assess the frequency, the amount, and the controllability of their alcohol use. It assesses current alcohol use while they're pregnant, and it also assesses for goals, so what the patient wants to accomplish. And then finally, it also allows for educational moments, so it kind of builds in those advising times right during the screen. So just going to go through their screening questions really quick. What do you think about alcohol use during pregnancy? So this isn't, you're not smoking and drinking when you're still pregnant, are you? This isn't that kind of degrading or leading question. This is very just, what do you think about alcohol use? This is getting at their understanding. Describe your alcohol use in the 90 days before you knew you were pregnant. So this is getting at, what were you doing? And it's kind of leading up to these questions that the patient knows are coming, but it's allowing for that safe space and that trust to develop before you're asking the hard questions. Which statement best describes your alcohol use since learning of your pregnancy? So I really like this one because it's not asking, are you drinking? But it is. It's asking it in a very safe, non-leading kind of way. Then you're going through the alcohol screen, and this part is the TACE protocol that we just went through. And then what would you like to see happen with your alcohol use now that you're pregnant? So getting at their goals and what they want to accomplish. And then the last part, asking, can I share some information with you? So this opens up those advising moments and those kind of education about next steps and things like that. So it's a really great screen, and I was happy to be able to go through this. So when you have a patient that you've identified as using alcohol use during pregnancy, the next step is really to advise them. And again, this is cutting down or quitting. Obviously in pregnancy it's going to be to quit, since there's no safe level of drinking associated with being pregnant. And does it work? Absolutely. So you guys really can make a big contribution to your patients' health and their lives by screening and assessing and advising. Brief multi-contact, it's important to know that's not all by physicians. Interventions definitely reduce risky and harmful alcohol use. And again, in pregnant women, brief advice on alcohol cessation validated in multiple studies as being useful and efficacious. When you're agreeing with your patient, you're setting goals, the plans to quit, and then using those motivational interviewing techniques, again, to help those not ready to make that change yet. Assisting with alcohol is a little bit more tricky because, as Dr. Piper alluded to, it is potentially life-threatening if they have alcohol dependence and they're going to be going through that withdrawal. So I would very much recommend a medical evaluation of any patient that you think meets criteria for dependence, if they're a heavy drinker, or if you're worried about them going through withdrawal, to make sure that they're in a safe place when they go through those withdrawal periods. After that, it's the same tenets, counseling and medication for maintenance and treatment after they've gone through the acute detoxification. I'm not going to go through the medications for alcohol use like I did for tobacco. They're not nearly as commonly used, and a lot of times it's very specific providers that are prescribing those medications. Again, we talked about the paucity of evidence for tobacco use in tobacco cessation medications in pregnant patients. There's even less for alcohol cessation medications in pregnant patients. There's maybe one that again kind of carries that you need to have a discussion about the risks and benefits, but you're really making sure that these folks are being treated by specialized providers if they're needing medications for alcohol use. Lots of support groups out there though for patients, Alcoholics Anonymous, Al-Anon for their family members, and then when I was developing these slides I also came across this Rethinking Drinking, and I really like that website. It's by NIAAA. It's got a little bit of an onerous website address, rethinkingdrinking.niaaa.nih.gov, but it's a really nice patient-oriented website, really complete, goes through a lot of information and gives a lot of really great resources for them. So I really liked that website. Again, arranging for follow-up at the end of the visit, very important. And I think these are the exact same bullets I went through with the tobacco use. Chronic condition helps you and the patient know that they're not alone in this. Multiple contacts are definitely better than brief single interventions. And so follow-up care of addictions, once you've kind of gotten them through this and you're seeing them back, it's important to remember that addictions are definitely a chronic disease. Relapse happens. Negative affect, like Dr. Piper talked about, might be the most powerful universal withdrawal symptom. So, you hear a lot of times people can get through the physical withdrawal symptoms with, a grain of salt. It's not easy to get through them, but this negative affect piece, the mood, the irritability is really difficult for people to get through. And we know that stress is a hard time for anybody, but women in particular will relapse in times of stress. So relapse happens, negative affect, stressful situations really make it prone to getting those relapse. And it's important just to not be discouraged when relapse happens, because as I'll talk about in a second, it happens just as often in drug addictions as it does in other medical problems. And I'll actually talk about that right now. So, framing, I think, always helps me keep reference to drug addictions and treating drug addictions. So you don't ever really get mad at your patients who have high blood sugar if they have diabetes, or who have an asthma exacerbation if they're asthmatics. Drug addictions relapse with the same rates that all these other chronic medical conditions relapse with. And so helping to kind of keep that frame of mind in reference just helps you not to get discouraged in treating your patients with addictions. And so with all of that really serious talk, I also came across this slide when I was preparing this presentation and just fell in love with it. And so you've got a banana and an apple at a beach, and the banana says, the apple says, I hate it when I'm at the beach and I get grit in my teeth. And the banana says, well, maybe you should just stop eating sand. And so the apple sticks his tongue in the sand and says, oh right, like it's that easy. So I just had to throw this in somewhere. I didn't really have a better place to throw this in. So in closing, we know that addictions are an illness. Changes occur in the brain, far-reaching implications, and all the different kind of nuances that the brain regions do. They all have changes when people get addicted to substances. It's not a habit. It's not something that patients can just switch off with willpower. And in order to help our patients, we need to identify them. So keeping in mind that addictions cross all ages, genders, cultures, social statuses, you're not screening a particular population, you're screening everybody. And you're screening them with validated tools so that you are catching the patient population that needs to be caught. And your help improves outcomes. So hopefully this talk has shown you some tools that you can use, and giving you the motivation to keep up your screening efforts, keep up your counseling efforts, because it really makes a huge difference in these patients' lives. The brief multi-contact interventions, medications, and referrals. So knowing what you have to offer patients, knowing your healthcare system, knowing the go-to counseling folks, knowing what, community resources are available to you are all really important things to kind of have at your fingertips to help these patients. And then remembering that it's not embarrassing, shameful, or a failure to have a relapse. They happen. And I think both patients and providers need to be reminded of this so that nobody's getting discouraged. You just come back in, we get you back on the bandwagon, and we keep going. With that, we'll close. Thank you very much again for having us talk. Both Dr. Piper and I wish we could be there in person, but thank you for all your efforts, and we'll go ahead and take any questions.